Good evening, everyone. Welcome to yet another webinar series of Daily Dentistry Demystified by Endo Haveli. I am Dr. Pandurang, a general dentist practicing since 20 years. My today's topic of presentation is the Glidepath in Endodontics, a simplified approach. Friends, in the last decade, there has been an unparalleled growth in the field of endodontic research and technology in every aspect. While focusing on these technological innovations, we often tend to ignore or forget the basics behind the procedures. And one such underestimated topic is the Glidepath preparation. The preparation of root canal system remains one of the most difficult tasks in endodontic treatment due to the complex anatomy of the root canal system with their irregular, non-circular cross sections. Multiplanar curvatures, bifurcations, lateral canals, apical ramifications, isthmuses, etc. Further adding to this complexity, subsequent iatrogenic mishaps such as ledges, apical transportation, instrument separation, perforations, or canal blockage may further complicate the procedure. In our daily endodontic practice, we may or may not experience such mishaps. These are some few examples of such mishaps. Here you can see the clinician is not able to negotiate the canal to the full working length. Another case where glide path is not achieved. Here also you can see the clinician is not able to achieve a glide path and patency. Canal blockage. Loss of the working length due to the canal blockage. Ledge formation. Instrument separation. Ledge formation again. You can see that there is one thing common in all these cases, that treating clinician is not able to reach the anatomic apex. Reason may be a ledge formation, canal blockage, wrong instrumentation, whatever, which results in the failure to create a glide path and a patency. In my opinion, inability to create a patency and glide path to full working length due to the wrong sequence of instrumentation and wrong instrument motions is the most common reason why we encounter such problems and see so many poorly prepared and obturated root canal systems leading to failure. Friends, in this presentation, I will try to simplify the steps in the glide path preparation, proper sequence of instrumentation, and step-by-step technique of glide path preparation within my limits of knowledge and experience. In aeronautics, the glide path is the approach path of an aircraft when landing. Its purpose is to establish a horizontal and vertical corridor that will take the aircraft to the proper location at the end of a runway, which gives a well-done feeling to the pilot. Similarly, well-done feeling in endodontics is a preparation of a glide path which allows all subsequent instrument to move smoothly from orifice of the canal to the apical constriction. What is glide path? It is the smooth radicular tunnel from the canal orifice to the physiologic terminus. It should be secured and reproducible so that number 10 or 15K file can slip and slide through this catheterized canal. A glide path is a pre-existing part of the root canal occupied once by a healthy pulp. It needs to be followed, not artificially made. And this is a small animated presentation of what glide path means. Please have a look at this video. You can imagine the smooth radicular tunnel from coronal orifice to the apical constriction. Now coming to the significance of a glide path. The purpose of endodontics is to prevent or heal the lesion of endodontic origin. In order to achieve this, root canal system must be three-dimensionally obturated. In order to be three-dimensionally obturated, it has to be three-dimensionally cleaned. And in order to achieve the 3D cleaning and shaping, glide path has to be successfully prepared. So the glide path is the answer. Why is the endodontic glide path important? Because it allows more safer and effective rotary shaping by creating a sufficient root canal space to accommodate the first rotary file. It reduces the risk of instrument separation. It maintains the original root canal anatomy, and it also minimizes the risk of iatrogenic mishaps. What should be the size of initial glide path? Its minimal size is super loose number 10K file, but the recent international protocol for glide path management suggests that terminus of any given canal should be at least 0.15 mm before rotary shaping to safely accommodate the tip of first rotary files. That means number 15K file at full working length is the ideal size of glide path. Now coming to the techniques of the glide path preparation. Glide path is achieved by manual instruments, that means hand files, and mechanically driven instruments, that is rotary files. Accordingly, glide path is divided into two types: micro glide path, which is done by the hand files, and macro glide path, which is done by the rotary glide path files. Now first we will discuss about the micro glide path, which is done with the hand instruments. Manual instrumentation to create a glide path remains an integral part of endodontic treatment. These are the common stainless steel hand files used for the micro glide path: K file, C file, C plus file, C pilot file, and D finders. Why stainless steel files? Because it has an excellent tactile sensation as compared to the nitrile files. When removed from the canal, the SS file gives an impression of the canal. The stiffness of the SS file aids in negotiating the blockages and calcifications. Now coming to the actual steps in the glide path preparation. These are the 6 steps in the glide path preparation. We will discuss each step in detail with video presentation as well. First step is reading of the pre-operative X-ray. Second step, access cavity, orifice location and initial scouting of the canal. Third step is removal of restrictive dentin or the coronal flaring. Fourth step is following the canal to its radiographic terminus. Fifth step, working length determination. And sixth step is to create a reproducible glide path. Now we will discuss about the first step, reading the preoperative radiograph. Reading the preoperative radiograph and mentally visualizing the 3D anatomy of root canal system is the first step towards the successful glide path management. It will help to determine the difficulty level of the case and the mechanical strategy. I will suggest you to read at least these following points in the radiograph before starting any root canal treatment. First is the curvature of the root. Prior to initiating treatment on any potentially curved canal, clinician must study 3 most important anatomical characteristics of a curved root. First is the degree of curvature, second is the location of the curve, and third is the radius of curvature. These will be the determining factors in selecting the instrument to safely negotiate the anatomy. Next is the canal space, whether the canal space is wide or narrow. It will help to determine the initial size of the file, like 6, 8 or 10 number. Third is the disappearance of canal. It is a suggestive of canal bifurcation or the trifurcation. Fourth is the calcification. It will help you decide the mechanical strategy of your instrumentation. In such cases, preferably use C plus files to negotiate through the calcifications. And fifth is the measuring the estimated working length. This is very important. It will help to determine the approximate length of your initial scouting file you are placing in the canal. If you are using an X-ray films, use the scale to measure the estimated working length. If you are having RVG, you can use the inbuilt feature in the software to measure the working length. So, this preoperative study of radiograph will guide you regarding the first file you place in the canal, degree of pre-curvature of file, and mechanical strategy. Now coming to the second step, we will not go in detail about these steps. Access cavity, orifice location, and initial scouting of canal. Although all our access cavities are driven by caries, but attempts should be made to preserve as much dentin as possible. Access cavity should be orifice directed. It will preserve the pericervical dentin and also provide a straight line access to all canal orifices. This is example of the orifice directed access preserving the pericervical dentin. I know it is not possible to achieve such access in each and every case, but attempts should be made to preserve the pericervical dentin. These are few clinical images of the access cavity. Next step is locating the canal orifices with DZ16 probe. It is mandatory to know the internal root canal anatomy and its frequent variations to effectively locate the canal orifices. That means the location of the orifices and number of orifices present in the tooth. Next step is initial negotiation or scouting of the canal system. These are my initial scouting hand files, number 6, number 8 and number 10K file. This is the video demonstrating the initial scouting of the canals. This is the most important step in glide path preparation. It is done with number 8 or 10K file. Chamber is flushed with the sodium hypochlorite. Then pre-covered file coated with EDTA gel is passively inserted till the resistance or 2 to 3 mm short of the estimated working length. Don't force or push the file to reach the apex. Please remember that in this step we are not reaching till apex. Use minimal watch pointing and up-down motion of the file. Minimal and very gentle. This is only scouting. Scouting means gathering an information about an area. Similarly, in endodontics, it means to get familiar of root canal system you are treating. It is not a definitive hand instrumentation. It is just to determine the orientation of canal orifices, degree of coronal curvature, and canal emergence. Use very minimal watch winding and gentle up-down motion. Here we simply want to give ourselves a sense of a flow within the canal, to gain a sense of confidence within the canal, knowing there are no calcific barriers. If you feel any resistance, then consider changing the scouting file to number 6, or perhaps even better, a C+ file, which has an active cutting tip and stiffer. This is the slide showing all the steps in initial negotiation or scouting of canal system. This is how the initial scouting of the canal should be. Here you can see the files are not reaching the apex during the initial negotiation of the canal. This is a small animated presentation of initial scouting of the canal and file motion. Very gentle up-down motion of the file. It is not a definitive instrumentation. Next step is the removal of the restrictive dentin at the canal orifice. Till now, we have discussed about the reading of the preoperative radiograph, access cavity, orifice location, and initial scouting of the canal. Next step is the removal of the restrictive dentin at the canal orifice. Straight line access into the chamber will not always ensure the straight line access into the canals. Here you can see the file is getting deflected from the straight line due to the restrictive dentin at the orifice of the canal. Inability to negotiate the canal to its full working length is due to the restrictive dentin at the orifice of the canal. This is called as a dentin triangle. This dentin triangle needs to be removed to gain a straight line access or radicular access. This dentin triangle projects itself to the opposite side of whichever canal you are approaching. For example, dentin triangle of mesial root, it extends towards the distal, and the dentin triangle of distal root, it extends towards the mesial. This dentin triangle needs to be removed, but it is not the next step after access opening. Please don't do this step immediately after access opening. It is done only and only after initial negotiation of the canal with number 10K file. Many complications can arise from clinician approaching removal of this dentin triangle in a wrong sequence of glide path creation. Very effective instrument to remove the restrictive dentin is orifice openers. These are the common orifice openers, 1 flare and SX. They should be used at a speed of 300 rpm and torque of 3 Newton-centimeter. These are the 4 rules to use these orifice openers. One is a backstroke brushing motion and never push down in the canal. Second is with a light pressure. Third, away from furcation. And fourth, not more than 5 mm tip in the canal. This file has a tip size of 0.90 mm at D0 and 1.2 mm at D14. And the severe taper of 9 to 11% of this instrument can cause taper lock and fractures. So these files should be used very cautiously. Many complications can arise due to the wrong use of the file. This is the small video demonstrating the correct use of orifice opener files. See the motion of the file. Backstroke brushing motion with light pressure. Away from the furcation. I am not pushing the file down into the canal. Just brush and follow. Just brush and follow. This is a small video demonstrating again the correct use of orifice opener files. Please have a look at this video also. File is not going deep into the canal more than 5 to 6 mm. This is the correct and this is the incorrect use of the orifice. Correct use of orifice opener files. You can see the file is deep into the canal, only 5 to 6 mm, not more than that. Next step is following the canal to its radiographic terminus. This is very important step in glide path preparation. After initial negotiation of the canal and coronal flaring, now the canal is followed till a radiographic terminus. It is basically a reaching of the smaller hand file to the estimated working length. It is usually done with the smallest hand file like 8 or 10 number K file depending on the initial canal width. Maximum time should be spent on this step. This is a small video showing the procedure of following the canal to the radiographic terminus. The chamber must be generously irrigated with sodium hypochlorite. Then number 8 or number 10K pre-coat file coated with the EDTA is passively and very gently introduced into the canal without forcing or pushing it. This initial instrument required only watch winding motion. This is always a safer way to advance a file down into the canal. Keep an eye on the stopper to check whether the file is progressing apically. Sometimes file will reach easily to the radiographic terminus, sometimes it won't. Once the file reaches the radiographic terminus, remove the file, irrigate the canal, and again shift to the next file. When you get the resistance, don't force the file, remove the file, irrigate the canal, again clean the fluids, and again pre-curve the file and reinsert in the canal, slowly advancing apically with watch-winding motion. This is very gentle watch-winding motion. You can see, don't force or push the file, otherwise you will definitely create a ledge or the canal blockage. Once the file reaches the estimated working length and is little loose, don't remove it. Now the instrument is made to work within the canal using small up and down motion, not exceeding more than 2 mm, but always in the presence of sodium hypochlorite. This motion will smoothen the canal walls. Gentle up and down motion, not more than 2 to 3 mm of amplitude. Again irrigate the canal. This vertical in and out stroke of the file with increasing amplitude will smoothen the canal walls and free the file in the canal. If you feel that file is too tight to do up and down motion, then this is the trick. Squeeze the handle of the file in the fingers, rest the fingertips on the tooth, and this way you can have a better control on the motion of the file. These strokes can be 10, 50 or 100 also. Take your time here and keep patience. If you have started with the number 8K file, repeat all above steps with number 10K file till it becomes super loose. This is the description of the steps which we have done in the process of following the canal to its radiographic terminus. Now in some cases, even number 8K file is also not reaching the radiographic terminus with all above techniques. That means you are in a really tight or constricted canal. In that case, don't force or screw the file in the canal, then following protocol is followed. This is the small video demonstrating the when your number 8K file is not reaching the apex. Don't force the file. Remove the file, irrigate the canal. Now step down to the number 6 file, preferably C file, which is more stiffer but with a light pressure. Pre-curve the file and insert this file in the canal with watch winding motion and slowly advance to the radiographic terminus with motions explained above. Once you reach the radiographic terminus, do little up and down motion to lose the file in the canal. Again repeat all the steps mentioned above for subsequent number 8 and number 10K file. These are the description of the steps which you have done. Please remember, if you feel an obstacle in the middle of the canal, don't force the instrument in an attempt to overcome it. Forcing is the natural or normal response and immediate reaction of a human being when you encounter a resistance. It must be avoided in a glide path preparation. An obstacle in the final millimeter of the canal is always misinterpreted as a calcification. But remember that calcification always progresses coronapically. It never happens that canal is calcified in the apical third only. So any resistance made prior to the apex is likely due to the following 6 reasons. Accordingly, you need to change and track different protocols. Reason number 1, sudden and accentuated curvature in the apical third. Here you can use different degrees of pre-curved files. Reason number 2, bifurcation or trifurcation of the main canal. Use small size files and use different degree of pre-curved files. Reason number 3, irregularity in the canal. Here vertical in and out strokes of the file can smooth the canal walls. Reason number 4 is a dentine triangle. Here you can use the orifice openers to remove the restrictive dentine. Reason number 5, canal blockage. Lot of irrigation, use of the smaller files and pre-curving the tip of file only 1 to 2 mm. And reason number 6, file size is larger than the canal diameter. Here you use a smaller size files. Now next step is the working length determination. Once your 10 number K file is super loose and reach the estimated working length, then take a final working length with the electronic apex locator. Till this point, even if your small size instrument number 6 or number 8 goes beyond radiographic terminus several times, there is no problem. Now you have a final working length. After working length is determined, next step is the use of a number 12K file. Why to use the number 12K file before number 15K file? Because the jump in the diameter of the file from 10 to 15K file at D0 is a 50%, and this can lead to the errors like ledge, zipping, transportation, blockage of canals, etc. Here you can see the diameter of the file at D0 is a 0.10 mm, while the diameter of 15K file at D0 is a 0.15 mm. So this is the 50% jump in the size. So this is my new file sequence: number 6, number 8, number 10, number 12, and number 15. This is the number 12.5K file from the BDW. Now next step is use of the number 15K file. A pre-curved number 15K file is used in the balance force technique to reach the working length. This is a small video showing use of number 15K file in a balance force technique. 15K file coated with EDTA gel is passively inserted into the canal. 90° clockwise, 270° anti-clockwise. 90° clockwise, 270° anti-clockwise. Repeat this motion for 1 to 3 times. And 360° full clockwise turn and remove the file. 90° clockwise, 270° anti-clockwise. 90° clockwise, 270° anti-clockwise, and at the end 360° full clockwise turn and remove the file. This is the balance force technique. It is not recommended to use file size larger than number 15 because flexibility of stainless steel instruments till number 15 size is sufficient to follow the anatomical curvatures. Beyond it, the instrument becomes stiffer and imposes its shape on the canal by deforming it. The file begins to deviate from the center of the canal, which can create ledge or perforation. Here is the small video showing the use of number 20K file in the curved canal leading to a ledge formation. Here you can see the file is deflecting from the center of the canal and creating a ledge on the soft and less mineralized dentin in the canal wall. Now this is the pre-op X-ray before we started the glide path preparation, and this is the after glide path preparation. You can see a smooth radicular tunnel from the canal orifice to the anatomic apex. Now next step is creating a reproducible glide path and a macro glide path preparation. Once you prepare the glide path till number 15K file, it's time to check whether it is reproducible. So what is meant by reproducible? When it is possible to push number 10 or 15K file from canal orifice to the full working length without any obstruction in its path very easily and several times, then it is called as a reproducible glide path. This is the small video showing a reproducible glide path. File is pushed from the coronal orifice to the apical terminus very easily with light pressure and several times. There is no interference in the path of the file from the canal orifice to the apical terminus. This is a reproducible glide path. Macro glide path. Now, rotary glide path files can be used to create a macro glide path. They will create a more smoother and regular glide path, making the root canal ready for instrumentation. Different rotary glide path files available in the market, like Glider, 1G, Edge into glide path, Scout Race, and path files. All of these instruments are made up of different metallurgy and has different geometries including cross sections, tip size, taper, etc. Due to the different physical dimensions and properties, these glide paths prepared with these instruments are not exactly similar. These are the commonly used rotary glide path files: Glider and 1G. Glider has a tip diameter of 0.16 mm and a variable taper from 2 to 8%, while 1G has a tip diameter of 0.14 mm and a taper of 3% with a symmetrical design. This is a small video demonstrating the use of a rotary glide path file. This is the Glider file. Go in a small pecking motion. Don't go directly till the apex. Coming to the apical patency. This is a very important step during the glide path preparation. Apical patency is a concept of using small hand file to keep the apical constriction open. Apical portion of canal is maintained free of debris by recapitulation with small files number 10K. A small flexible K file is moved through the apical constriction 0.5 to 1 mm beyond minor diameter without widening it. This is a small video showing maintenance of the apical patency. Here we can see number 10K file is passively introduced into the canal to go beyond the working length without widening the apical diameter. This is to verify the glide path. This file should be used with a small back and forth motion of 1 to 2 mm. Secrets of successful glide path preparation. According to my opinion, These are three important skills or habits you need to master during the glide path preparation. First is the hand filing motion, second is pre-curving the hand instruments, and third is the patience, restraint, and gentleness. Hand filing motions. We require only three filing motions during the glide path preparation. One is the watch winding, second is the watch winding and pull motion, and third is the balance force technique. Watch winding. In this motion, you basically reciprocate the file between the thumb and forefinger in 30 to 60 degree as you advance the file into the canal. Watch winding and pull. It involves watch winding to a resistance and then pulling the file out of the canal or out of the area of resistance. And third is the balance force technique. Here the instrument is inserted into the canal in a clockwise motion with 90-degree turn. With continued apical pressure, go counterclockwise to 70-degree turn to cut the dentin. Do this 1 to 3 times before removing the file. Then turn the file full turn 360-degree clockwise to load the debris onto the file. Remove the file, clean the fluids, irrigate the canal, and again reinsert the file. Generally, I recommend to use number 6 and number 8K file in a watch winding or watch winding and pull motion, and number 10 and above file sizes in a balance force technique. Second skill or habit you should master is a pre-curving the instrument. All instrument must be pre-curved even if roots are straight. Pre-curved file is a smart file or intelligent file. The amount of pre-curvature depends on the radiographic appearance of degree of curvature of the root. A pre-curved file makes its way more easy among the obstacles and calcifications. How it works? As the pre-curved file is withdrawn from the canal, it creates an envelope of motion that scribes the side walls of the canal at random contact points, eventually widening the canal space for next larger file to follow. Ideal instrument for bending the file is endobender, but can be done with the orthotic plier or tweezer in a gentle way. These are the different degrees of pre-curvature of the file. Accordingly, you can pre-curve the file depending on the curvature of the canal you are treating. These are a few cases I would like to show demonstrating the proper glide path preparation resulting in a predictable endodontics. I often spend maximum time on glide path preparation as compared to the actual instrumentation of the canal. This is the case of a radix intermolaris. Proper sequence of instrumentation and proper hand filing motions resulted in a proper glide path, which can be ideally shaped and obturated. This is another case, very long roots, about 25 to 26 mm of the working length. Maximum time is spent on the initial negotiation and glide path preparation of the canal. This is a case of confluent canals in the mesial root. Same protocol is followed, resulting in the proper glide path preparation, resulting in a predictable endodontics. Another case of acute curvature in the distobuccal root. Every step in endodontic treatment is important in order to achieve the desired end results. However, creating the correct glide path for the canal you are treating will make each of the following steps in your treatment protocol much easier to perform, resulting in a cleaner, well-shaped canals that can be ideally obturated. So spend maximum time on the glide path preparation. This is another case. Proper sequence of instrumentation, proper hand filing motions, resulting in a proper glide path, which results in a continuous tapering preparation without glitches, fulfilling all the mechanical objectives of a shaping. This is the case with the middle mesial canal and isthmus in the mesial root and accessory canal in the distal root. Here you can see a proper glide path preparation results in the well-shaped canals, which can be three-dimensionally cleaned and three-dimensionally obturated. This is the case with 90-degree curvature in the apical third in the lateral incisor. Proper sequence of instrumentation and proper protocol resulting in a proper glide path preparation. This is another case with different anatomy in the distal root. Case with a curvature in the distal root. This case, you can see the well obturated canal because of the proper glide path preparation. This is another case with multiple portal of exits in the distal canal. Case with apical trifurcation. Case with the acute curvature in the distal root in the third molar. Again, this is a case with the curvature in the distal root. Always remember that every root canal has some form of curvature. Many of them have tendency to curve and ramify in the apical portion. And apical pulp tissue is more fibrous due to the presence of more collagen fibers at the portal of exit where the pulp and periodontal ligament meets. So maximum care should be taken during the negotiation of the apical third of the canal to avoid the mishaps. Another case with the proper instrumentation resulting in the proper glide path. Unless you shape it, you can't clean it. Regardless of how efficient, safe and simple rotary system one is using, if glide path is not present, mechanical file will eventually break. And before concluding, let's sum up my steps in the glide path preparation. Flush the chamber with sodium hypochlorite and initial negotiation of the canal with 8 and 10K file 3 mm short of the working length. Coronal flaring with orifice opener file 5 mm deep in the canal. Pre-curved number 8 and number 10K file is taken to full estimated working length in a gentle watch winding motion till it becomes super loose. Then irrigation and recapitulation and cleaning the fluids after every instrument. Final working length using apex locator. Then use of number 12K file till the working length. Maintain the patency with number 8 and number 10K file. Then use of a number 15K file till working length using balance force technique. Patency, irrigation, recapitulation and pre-curving the file is a must. Now you can use the rotary glide path file of your choice till the working length. And now canal is ready for rotary instrumentation. And these are my two